thank you very much for inviting me. And in fact, before I moved 6 months ago, I had the pleasure to live in Manhattan for 23 years, working at Memorial Sloan Kettering Cancer Center. And you can imagine I still maintain my home here as a second home because I can't do without Manhattan. And you can imagine my confusion yesterday when I left this room and I walked into 82 degrees. I had no idea whether or not I'm in Florida or am I in New York. You get confused on and often. So you heard a lot of things about targeted therapy already. You will notice there will be a little bit of overlap of some of the slides. I think that's just the rapid development that we are encountering right now. But the question comes up not only with AML now, and as a transplanter it comes up to me all the time. Are you still in business with transplantation? We have all the new drugs for multiple myeloma, for lymphoma, CAR T cells with a replaced bone marrow transplantation or stem cell transplantation, and now the novel drugs for the treatment of AML. How does it infect or affect the indication for stem cell transplantation? The answer is it needs to be integrated, and I will try to touch upon this a little bit. You just saw this, but just two things to point out again. Does this work? Do I see? Oh, okay. So there was very little activity for quite some time, but interestingly enough, 7+3 has really not changed and is still the background of treatment for AML. What has not changed at all either is that bone marrow transplantation is still a primary indication for a majority of these, although I would have liked to talk about changes in the field of bone marrow transplantation for AML, but it's still part, and I will try to address it on and often. Now, we just heard that Mylotarg gemtuzumab came on the market in 2000 and then was withdrawn 10 years later because of a very high frequency and mortality. In fact, based on VOD or SOS, as it's called now, it was withdrawn for that reason. But most of these patients were also undergoing transplant, and so it's not relatively unclear whether or not it was a transplant-induced combination with Mylotarg to explain this. And then here all hell broke loose not too long time ago. In fact, when I moved to Miami, it broke loose. Midostaurin was approved, gemtuzumab came back, CPX was approved, and we also heard a little bit about the IDH inhibitors that also came up at this time. Now, again, for me, and I think for everybody, risk stratification is really the key from the beginning of diagnosis, and risk stratification should really also guide how to recommend treatment, how to initiate treatment, and how to talk to the patients, frankly. We know that we have cytogenetics that are favorable, intermediate, and poor risk, and we now have also abundance of molecular abnormalities that would, in combination maybe with the cytogenetics, explain whether or not you have a favorable, intermediate, or unfavorable outcome. And I think it's worthwhile to tell the patient whether or not this will affect, and we should look for transplantation early on and include a donor search in the management. Now, what is also interesting to note that there is an age difference improvement in outcome of treatment. So patients younger than 60 years were doing better over time. This is the improvement we see from 1960 to now 2010. But to be honest, as of now until 2016, this has not really changed for the patient population that are older than 60 years. Although maybe the age, I think Richard Stone will address that also. The age alone may not really, maybe just a number, and we shouldn't really stare at the number and should basically look at the biological fitness of these patients and proceed. Now, for me again, so with all these new treatments that are available, there are lots of questions coming up, and I'm not going to provide you with a lot of answers. I think I wanted to take advantage to also ask the next series of questions that are arising. But how do we integrate all of this into the treatment now we have? And what I did here, timing of targeted therapeutics and allogeneic transplants, basically there is a significant overlap now in the questions arising. How do we do this? We have, of course, induction, consolidation, maintenance, and then rescue. But when do we do what? Now, when do we do gemtuzumab? What case do we include midostaurin, or should we think about combinations of these drugs, or when is the allogeneic transplant indicated? So therefore, we have the same questions, that is age, functional status, comorbidity index. We have the biological characteristics here, and then the question, when are we going to do this administration of these drugs? First remission, later, blast crisis, or should we get them into remission first, and so on and so on. Now, we just saw this and heard about it. Again, briefly, gemtuzumab is an anti-CD33 directed IgG4 monoclonal antibody that is conjugated to calicheamycin, and once these binds to the surface, calicheamycin gets internalized and therefore induces cell death. We heard about the limited outcome of the initial trial, where gemtuzumab was administered at a dose of 6 milligrams per meter squared on day 4. There was no real advantage of 7+3 compared to 7+3 plus gemtuzumab. But we also heard that there was significant higher frequency of VOD or SOS, and the drug was withdrawn based on that. On further review, though, then the reduced dose of gemtuzumab at 3 milligrams per meter squared at 1, 4, and 7 induced a favorable outcome, or better outcome, in patients with favorable risk AML. As we just heard, this didn't hold true for intermediate risk and high risk. So therefore, at this point, we can maybe conclude that gemtuzumab may be indicated in CD33 positive AML patients that have a favorable risk in combination with 7+3. A question that will arise, I just build it in here now. These patients, of course, not all cured. Once they relapse, and in relapse, you start thinking in even this good risk patient population to consider allogeneic transplant. Will this then, as a consequence, once they undergo transplant, have a higher risk of VOD? That's an interesting question, I think, that may arise down the road, one of them. Now, we heard molecular characterization really is a part of risk stratification now. The most patients, the highest mutation frequency we'll see in the FLT3 compartment of about 35% of all newly diagnosed AMLs. And then there are a few other ones that are also of consideration. FLT3 comes in two flavors, the ITD and the D835 mutation. And this is the historic review of patients that were diagnosed without FLT3 mutation with one of these, and you can clearly see that their remission duration and overall survival is worse compared to those who did not have a FLT3 mutation. This also holds true if you look at patients with FLT3 mutation that undergo allogeneic transplant. In spite of the fact that these patients do better compared to chemotherapy alone, they still have a poorer outcome with respect to outcome after allotransplant. Here, though, would have been a talk about the bone marrow transplantation varieties that can be administered to these patients, but this is just an overall, demonstration of that effect. Again, historically, we can say in this high-risk patient population, FLT3 mutated AMLs, transplant is better than chemotherapy in terms of relapse-free survival and overall survival. Therefore, midostaurin was then tested, and I'll keep this short because Richard Stone is going to talk after me. But again, so if you have integrated midostaurin now in the induction regimen 7+3 in this randomized study, there was a clear improvement, as you've seen before, for those who also had the midostaurin. But for me, again, from this perspective, important to note that 57% of patients in the RATIFY study also underwent allogeneic transplant, and the overall improvement, if transplanted, despite of the fact that midostaurin was added into the conditioning regimen, in the induction chemotherapy, the outcome of patients transplanted in first CR was better compared to those that were transplanted at a later time point. So this means to me that the addition of midostaurin does not necessarily exclude or replace bone marrow transplant. But we, of course, will have a better outcome if we add the midostaurin to the induction chemotherapy. So that's one of the conclusions right there. Another question that will arise, this was an interesting study presented as an ASH abstract right now, where 4 cohorts were compared, and you see reasonable numbers in patients that had FLT3 mutation. One group got induction chemotherapy only. The next group got induction chemotherapy plus FLT3 plus midostaurin in this case. Then the other one got induction chemotherapy followed by allogeneic transplant, and cohort 4 got all 3. It is induction chemotherapy 7+3, FLT3 inhibitor, and allogeneic transplant. And you can see, interestingly enough, you really have to pull the full Monty in order to have the best outcome. Cohort 4 with all 3 included has, although short-term follow-up is short here, but apparently has a better outcome. Now, this was touched upon, and I'm going to leave this to the previous presentation. I'm not going to go into this IDH mutation right now, and therefore the questions that I think are pertinent coming up now with these new drugs: will novel agents affect our approach to induction chemotherapy? Is one of those. Do we have to deal with new side effects or safety issues? Will the timing and or use of allogeneic transplant be affected? And what about novel drug combination therapies? We always have one approved, and then the question is, can you combine those? Question, that's the obvious one from my point of view, is what happens if you have a FLT3 positive, C33 positive AML in a patient that is not a transplant candidate, or a patient that may not even be tolerable to induction chemotherapy? Would this be worthwhile to test? And I would be keen to run or propose a clinical trial to assess this in these 2 patient populations. Other questions that may arise, how about maintenance treatment after allotransplant? So we don't know much about midostaurin after an allogeneic transplant. Would this be an idea to include it? Because in the RATIFY study, most patients had a short term of midostaurin administration only because they underwent allotransplant afterwards and therefore was discontinued, but can it be given after allotransplant? So lots of new questions I think are coming up, and with this I thank you for your attention.